How's the COVID scene that side?
Yes,
Our
we
side,
can go ahead.
on the other side is quite okay, not bad.
Mm-hmm.
Quite less. How is Bombay Hospital going?
Okay, Bombay Hospital is okay. Pretty chill
So
right
we
now
can
with
start.
respect to COVID work. Non-COVID work is pretty intense. So that is taking most of the time right now.
Good. I think that's a good sign.
Yes, that's a good sign.
So we can start. We are on live.
Yeah.
Yes.
So good evening, everyone, and welcome to today's webinar on antivirals in COVID-19, hit hard, hit early. We have with us our guest speaker, and I would like to take a moment to introduce them. We have today with us Dr. Avya Bansal. Dr. Avya Bansal is a consultant pulmonologist at Bombay Hospital and Medical Research Center, Mumbai, having completed his MD and DNB in respiratory medicine with top honors. He is the youngest recipient of the fellowship of Asian Pacific Society of Respirology. He has a keen interest in allergy and asthma, COPD, tuberculosis, respiratory infection, interstitial lung disease, lung cancer, and sleep medicine. He has the fellowship and membership of ICS, NCCP, ERS, ACCP, IAB, CCI, AMC, APSR, and ATS. Dr. Avya Bansal has been at the forefront in managing COVID-19 patients at Bombay Hospital from the very beginning, and he is also working with the BMC to supervise the NSCI facility. Along with Dr. Avya Bansal, we have us as a speaker today, Dr. Kapil Rathi, who is a specialized in internal medicine, chest physician, and infectious disease specialist. Also, he is a specialized in the diabetology, cardiology, and critical care medicine. He has a 14 years of clinical experience and a vast experience of treating 1200 plus COVID-19 patients. Also, he successfully treated 500 plus patients with favipiravir. Besides completing his graduation and post-graduation in medicine, he underwent the specialized training in diabetology, cardiology, and critical care from various reputed national and international institutes. He is an active member of Kurla Suburban Doctor Association, Andheri Parle Physician Association, and various other medical bodies present in India and abroad. He has also been a co-investigator for various clinical trials and surveys conducted by Indian and multinational companies. With this, let's begin with the webinar. Over to you, Dr. Bansal.
Hi. Thank you so much, Manohar, for this pleasant introduction. I welcome my co-speaker, Dr. Kapil Rathi, and I hope we can have a wonderful session on antiviral, hit early, hit hard. Sairam, can you share the presentation, please? Yes. Next slide, please. So the contents of today's presentation would be the current COVID-19 scenario, COVID positive patients and asymptomatic, benefits of starting early favipiravir within 72 hours, and importance of treating family members, post-COVID complications in patients who have recovered and not treated with antivirals, and home quarantine isolation techniques for asymptomatic patients, and diagnostic tools and the role of inflammatory markers such as D-dimer, ferritin, IL-6, and CRP. Next slide, please. So the COVID-19 pandemic in India, the present scenario, I think this does not need any introduction or any talk because the common people and the general physicians know much more about the disease than us because they see maximum number of patients. However, just to touch upon it, the novel coronavirus disease, COVID-19, has already affected over 6.9 million people, claiming more than 4 lakh lives in over 200 nations all over the world. As on 1st December 2020, 94.6 lakh cases were reported in India, with 1,37,659 deaths and 88,89,585 cases recovered. The ICMR mentioned that 80% of cases in India were either asymptomatic or mild, 15% were moderate, and 5% were critical. Next slide, please. Now, the challenges in COVID-19 pandemic area are the rising number of COVID-19 positive cases, the limited health infrastructure, the overburden on healthcare system, cost of the COVID-19 treatment, and increased incidence of post-COVID-19 complications, even in asymptomatic patients. What are your thoughts on this, Dr. Kapil? Do you agree with this, please?
Yeah. I think that's absolutely right. So I think you're right on the money. That is how it is. So probably I totally agree with you what you have said.
Okay. Right. Sairam, next slide, please. So the symptoms of COVID-19 are cough, shortness of breath, fever with chills. It could also have atypical presentations such as generalized weakness, muscle pain, body ache, vomiting, diarrhea, and a new onset loss of smell or loss of taste. So the primary symptoms are fever, generalized weakness, cough, and if a symptom is, if the patient is having a moderate disease, it will go on having difficulty in breathing as well. We also see a lot of atypical symptoms such as vomiting, diarrhea, loss of smell and loss of taste is another symptom which we've encountered. Dr. Rathi, what is the percentage of atypical symptoms you've encountered in your practice?
So I think that is something which is very important, and what we have seen is almost 20 to 25% of your patient will come with atypical symptoms or symptoms which are not related to upper respiratory infection. So that is something which is so that includes basically, I think paraguasia and basically anosmia are very common. These two symptoms are actually pathognomonic for COVID-19 as of now, and also loose motions, diarrhea, probably fatigue, chronic fatigue or very long weakness is something which patient really come with. So you can just have that weakness which was probably with chikungunya in that time period in time.
Right.
So probably these are a few symptoms which actually differentiate from your other respiratory infections. So that is my take on other atypical symptoms.
No, very well said, because even in my practice, I've seen about 20 to 30% of atypical symptoms. More often, there's a fever followed by 1 week of being asymptomatic and then sudden loss of smell or loss of taste. So that's more often than none the patients present to us. Next slide, please. Now, the classification of COVID-19 patients would be as mild, moderate, and severe. The mild patients would be with uncomplicated URTI, with no difficulty in breathing, with normal oxygen levels and a normal respiratory rate. This could present with maybe a 1 episode of fever or some body ache, which subsides on its own and doesn't require any form of treatment. The moderate would be pneumonia with signs of severe disease, no signs, such as the oxygen saturation would be less than 94% with a rate of more than 24 and difficulty in breathing. The severe would be the patients requiring mechanical ventilation. Now, in this, I would also say patients requiring a non-invasive ventilation and even HFNC would classify as a severe disease, with obviously difficulty in breathing and a saturation levels of 90% without support and a respiratory rate of 30. Now, this is a very gray area. It's a very gray differentiation between a moderate to severe, because one person's moderate may be somebody else's severe. A lot of comorbidities have to be looked into. But typically, I see patients who are not doing well on a non-rebreathing mask. I would classify them as a severe disease. What are your thoughts on this, Dr. Rathi?
Yeah, I think that is very well defined. It's a very simple classification to have, because so that our practitioner they actually understand the gravity of disease, so that they can differentiate and be aggressive. So anything what we have done is that any person who requires more than 6 liters of oxygen probably goes into severe category, and that is how we differentiate. So obviously, any person who's on HFNC or any kind of non-invasive or invasive, that automatically warrants and critical care and everything. But a person who's required oxygen which is going up, say probably 6 liters is something where I'll differentiate, or probably it's an arbitrary marker. There is no guideline for that, but probably person requiring. So once patient is not on a simple nasal mask, goes on rebreathing, something like that, probably you are getting worse, or probably you are hitting that severe category.
Alarm bells are ringing off. So we better shift the patient to the ICU rather than the HD.
Perfect.
I agree. Yes. Next, please. Now, what are the symptomatic differentiation of ILI, H1N1, SARI, and COVID-19? Now, what we need to understand is that every cough and every fever is not COVID-19. We're forgetting the good old dengue and malaria, which is still very, very predominant in Bombay. Okay. So now let us just see the differencing symptoms and the overlapping symptoms between an influenza-like illness, H1N1, a severe acute respiratory infection, and COVID-19. So now the striking feature is that diarrhea and anosmia are classical signs of COVID-19, although they are very rarely encountered in, say, maybe 20 to 30% of the population, but it differentiates between an H1N1, an acute respiratory infection, and influenza-like illness. However, certain viral illnesses are notorious and have known to cause a gastrointestinal disturbance, which we call as a viral GE. Fever, myalgia, cough are overlapping symptoms. Sore throat, loss of energy are again overlapping symptoms. Breathlessness is more common in an SRA with H1N1 and COVID-19. Now, another feature which is not mentioned here, which I would like to say in an influenza-like illness, is rhinitis. Generally, a running nose, sneezing goes against COVID-19. However, we have seen 15 to 20% patients do have a running nose and sneezing, but it goes more in favor of an allergic rhinitis and an influenza-like illness, which can typically wax and wane. Dr. Rathi?
Yeah, that's very common. So typically, more of allergic symptoms, more upper respiratory symptoms are probably, it classify itself to maybe an ILI or maybe an, some kind of flu or a non-specific viral illness. But yes, there are a couple of features. The more respiratory, more lower respiratory kind of infection, and probably atypical infection that actually separates out COVID from other M3. And being in pandemic and considering all the epidemiology around us, probably you will be 9 out of 10 times you will be right in diagnosing. But yes, one need to, at general practitioner level, you need to understand that nowadays, because nowadays the winters have set up, probably COVID is getting little low. You are getting a lot of other viral infections which are coming up, which
Right.
might mimic like COVID. So just be
Right.
careful now so that you don't overdiagnose.
Correct. Correct. I absolutely agree with you. Next, please. Now, the RT-PCR test, which is a reverse transcript test, polymerase chain reaction, is the most sensitive technique compared to other PCR-based techniques. Now, it is used for the diagnosis of H1N1, influenza diseases, and your SARS-CoV-19, which is the most commonly used test which we use. So that's nothing, and it's got a sensitivity of about 60 to 70%. Now, the chest X-ray has a classical peripheral shadows, which we see. We've got these pleural peripheral enhancements, which are more appreciated on a CT scan as ground glassing. Okay, and based on the CT scan and the chest X-ray, we classify the patient as having a mild, moderate, or a severe disease. So a scoring system of CORADS 5 out of and a scoring out of 0 to 25 will tell us the mild, moderate, and severe nature of the disease. So the score of less than 10 is typically a mild disease out of 25. Between 10 and 15, we would consider it to be moderate, and say maybe more than 15 would consider a severe disease. Now, this is done on basis of a CT scan. However, sometimes a CT scan is not very practical and affordable in a peripheral setting, which is why a chest X-ray would be helpful. So whenever we see these peripheral opacities in today's day and age, we must always think of COVID-19. Next, please. Now, we have already discussed the CT scan. Dr. Ati, how useful do you find the CT scan in clinical diagnosis of COVID-19?
I think you will agree to me that probably we are moving from, COVID is something which is, the city has given us immense confidence in diagnosing COVID-19, and probably CT is the gold standard if
Yes.
you consider as far as radiology is concerned. I think we can
Yes.
pick up. In fact, a lot of we have seen, and you must have also seen a lot of swab negative and CT positive patient what we
Correct.
have seen. CT has got a
Absolutely
high
right.
sensitivity so that we can actually pick up disease in early stage and probably do. So I think CT is the thing where, if you want to order one test, probably given a choice, probably CT is the answer.
I agree with you, because the RT-PCR has got a sensitivity of only 60 to 70%. Like even today, we have a couple who's admitted under us. The wife is having just a mild fever and a cough, and a RT-PCR is positive, whereas the husband is on an NRBM and his 2 RT-PCRs have come negative, but his CT has picked up and is showing a score of 16. So I completely agree with you that CT is definitely the gold standard. If you've got one test to pick, let us do the CT scan if the patient is symptomatic. I agree with you. Next, please. Now, diagnostic tools for differentiating ILY, H1N1, SARI, and COVID-19. The RT-PCR obviously will help us distinguish between all these 3 tests. And the CT scan will also be typical for COVID with a peripheral involvement. Now, sometimes there may be an atypical feature on the CT scan, which will make it difficult for us to differentiate between a atypical pneumonia or an H1N1. In such cases, an RT-PCR would be helpful. A CBC count will be low in any viral and atypical infection, or it will be normal. If you're suspecting a bacterial pneumonia, only then will the counts be elevated. An influenza-like illness will typically have a normal oxygen saturation. H1N1 can have a normal to a reduced. SARI and COVID-19 may have a normal or a reduced oxygen saturation level. Next, please. Now, what are the important investigations? The CBC would typically show a neutrophilic predominant with low lymphocytes. A D-dimer of less than 0.5 is normal, which can be elevated because it's a hypercoagulable state and it goes in favor of coagulation and pulmonary thrombosis. CRP levels are high, typically in an advanced patient, in a symptomatic patient always. Asymptomatic patients generally have a normal CRP level. Ferritin levels will be more than 250 in, again, symptomatic patients. IL-6 is an indicator for inflammation. However, I am not very convinced with this marker because we don't generally use this. But yes, for Theoretical and documentation purposes, IL-6 is also elevated and LDH levels are also pretty high. Dr. Rathi, what is your take on the role of inflammatory markers in COVID-19?
So I think, again, very important to understand how do you place this marker, at what point of time in disease you order this marker, because it can be little fallacious sometimes. Typically, I'm talking about IL-6 level and everything. So yes, as we all know, COVID is a 2-week disease. First week is infection, second week is inflammation. So probably, some CRP, all these are non-specific markers. The only problem is that there's nothing specific. It can go sky high in any kind of thing. But yes, given a scenario, given a clinical condition, patient in front of you, reports and everything, so that will make a complete diagnosis. They help you us, at least they help you us not in initial diagnosis, but probably in prognosticating, and probably in long term whether this patient is going to get better or going to get worse. So that is how I take this investigation like that.
I agree with you. So patients who are treating at home with a mild or an asymptomatic disease, I often tell them to repeat the CRP, ferritin and D-dimer levels every 3 to 5 days. And if the CRP ferritin is showing an increasing trend, only then do I consider giving steroids to the patient, which I'm sure even you practice, because all of us who have been doing this from the first day have been following the same 2-week approach, steroids in second week if inflammatory markers are high. So I think CRP, ferritin, D-dimer would be the 3 markers which we routinely do regularly once the diagnosis is made to assess the prognosis and the severity and improvement in the patient. Very well said, Dr. Rathi. Next, please. Now, what are the complications of COVID-19? Now, this I'm directly going to ask Dr. Rathi, since he has treated more than 1,000 COVID-19 patients like me. Now, I want to know his take on what are the complications he has seen typically in COVID-19 patients. Let us stick to moderate and severe COVID-19. Let us not assume mild COVID-19 in this case.
Yeah, I think, it was, the scene have changed a little bit. Initially in the month of April, May, June and July, we're having a lot of mortality, a lot of people, receiving a lot of probably tocilizumab and a lot of immunosuppression and everything. So you're seeing a lot of complication initially. And then probably, yes, to list them a few, we all know pulmonary fibrosis is something we are all concerned. Myocarditis, myocardial ischemia, in fact, infarction. I have seen at least 4 or 5 patients who have gone back to home and then suffered an infarction, probably related to COVID or related to prothrombotic state. Obviously, DVT, pulmonary embolism, myocarditis, and new onset diabetes, or probably a lot of rhabdomyolysis in some patients I have seen. So there are a whole list of complications, but I think to list maybe top 3: pulmonary fibrosis, myocardial infarction or ischemia, or some kind of heart failure if patient is already pre-comorbid, and probably new onset blood pressure or diabetes is something what we are seeing. And maybe very rarely we see some, but yes, I have seen a couple of pulmonary embolism also post-COVID. So yes, we need to be very vigilant, but yes, there are side effects. There are side effects of drug, and there is a lot of sequelae post-COVID. But to put in the perspective, I think it is less than 10% of all the given patient. So that's a good news. But bad news is that once it happens, they probably will require lifetime treatment.
And also, there's another thing which is not mentioned here. I would not say a complication. I would say a sequelae, rather like a chronic fatigue kind of a syndrome. The patients have complained of generalized weakness for weeks after recovery as well. And any number of multivitamins have not been able to help them. All the levels are okay. So, I've just told them to just let it wait, and it often passes off in a couple of weeks. So this is something also which I've observed, like a chronic fatigue and a chronic weakness kind of a picture, which is a post-viral state. Right. Next, please. Now, what is the role of the antivirals favipiravir? Let us discuss this in detail. Now, favipiravir, also known as Favipira or Favilavir, is an antiviral drug being developed by the Fujifilm Group Toyama Chemical of Japan. It's an antiviral agent that selectively and potently inhibits the RNA polymerase. It has shown activity against influenza virus, West Nile virus, yellow fever virus, foot and mouth disease, as well as other flaviviruses in the area. It has been approved for treatment for COVID-19 by regulatory agencies of India, China, and Italy. Next, please. Now, the mechanism of action is that favipiravir is incorporated into the cells, converted to favipiravir ribofuranosyl phosphate by the host cell enzyme. This triphosphate form, favipiravir RTP, inhibits the viral RNA polymerase activity. So at the end of this complicated picture, all we need to know is that it inhibits the viral RNA polymerase activity and is a potent antiviral at the end of the day. Next, please. Now, salient features of favipiravir is a broad spectrum antiviral. Early initiation within 72 hours helps in the rapid reduction of the viral load and disease progression. It offers faster viral clearance within 4 days and symptomatic relief within 7 days, reduces the chances of hospitalization, reduces the overall treatment cost, and limits the future complications of post-COVID-19 recovery. Dr. Aki, do you agree with this?
Oh yes, I think I'm more in with you for this. This statement what you have made. I think favipiravir, I should say it's not a game changer, but at least it has given a lot of hope to our COVID patient and probably to all of us in treating all your mild to moderate patient. And I think favipiravir has made the difference. That curve, the mortality curve, which has gone down significantly probably after June, is something to do with both drug. I'm not saying favipiravir, but remdesivir and favipiravir. But yes, it's a broad spectrum antiviral. And till date, or till to best of our knowledge and best of in our hand, I think it is doing wonders to all of our patients.
Also, like you rightly said, that the mortality which we have seen has come down, more so rather than the reduced virogenicity or the viral infectivity of the virus. I think even you would agree that it is because of we have learned what not to do in COVID-19 rather than initial treatment was all blind, helter-skelter. Now we've realized that we have to be very simple, A, B, and C, steroids, antivirals, anticoagulation, and that's about it. So yes, I agree with you. Sairam, next, please. Now, favipiravir has been in a number of studies. A lot of our colleagues have also propagated the use of favipiravir. Now, the COVID task force recommended the timely use of favipiravir to reduce the severity of the infection. It's a safe drug and effective treatment for mild to moderate COVID-19 cases, and it may also reduce the duration of clinical signs and symptoms. Next, please. Now, the study and the trial showed that 150 patients with mild disease were chosen for the efficacy and safety of favipiravir. Patients received 3600 mg on day 1, that is 1800 mg BD, followed by 800 mg BD on day 2 for a maximum of 14 days with standard supportive care. They were classified as a mild disease in 90 patients and a moderate disease in 60 patients. Next, please. And it showed that 70% of the patients with favipiravir achieved a clinical cure by day 4. So this again proves that it prevented the disease progression and it helped in faster viral clearance from the study group. Hit hard, hit early. That's the motto of our theme today, of our topic. Now, what is the dose of favipiravir? As you all know, that day 1 is 1800 mg twice a day, followed by 800 mg twice a day on day 2 to day 7. So you can take 2 tablets of Favivir 800 mg plus 1 tablet of Favivir 200 mg. And in the evening, same. The next day, you can take 1 tablet of Favivir 800 mg and in the evening, 1 tablet of Favivir 800 mg. I don't think there's any doubt in this because it's a very crystal clear dosing regimen which we've all followed. That's 1800 mg BD on day 1 followed by 800 mg BD on day 2 to day 7. Some protocols and guidelines extended to 10 to 14 days, but I'm very happy with giving it just for 7 days. What about you, Dr. Rathi? Do you extend it beyond 7 days?
No. I think that is the crux. I have probably only 10 patients I have given for 10 days. Otherwise, 7 days is more than enough.
More than enough.
Is that if patient doesn't improve in 7 days, probably is not improving another 7 days another. So probably whatever response has to be there, it has to be in first 7 days.
Yeah, and in a few number of patients, I've even given it only for 5 days. Because then the patients often start cribbing that we are asymptomatic now, please stop the medication. And they themselves stop the medication. So I think 5 is more than 5 is something which we've all done. Yeah. Next, please. Now the use in special population. Now we have to be careful with favipiravir in hepatic and nephro patients because it tends to increase the liver enzymes. The cutoff for which is 200, that is 5 times elevation of SUT, SGPT, and a creatinine clearance of less than 30 somewhat a contraindication. Now, we don't have enough studies to show that it's helpful in pregnant and lactating women. So I stay away from the drug in pregnancy and lactating women. What about you, Dr. Rathi?
Yeah. In fact, there is absolutely no for this drug to be used in all whatever the contraindication. They're very standard contraindication. So probably we should not mess with all this contraindication. And yes, means if patient is that severe enough where he has to be, probably he or she need to be in the hospital and treated with some other drug. So patient is mild, moderate, and probably if not that many symptomatic, so probably we should follow what are the contraindication and we should not use this drug.
even in children, I've never given a single child favipiravir. I think children recover on their own and often need no treatment.
Yeah.
What are your thoughts on this, Dr. Rathi?
Yeah, I think I've not used in anyone who's less than 16 years of age, to be honest. All my series
Correct.
is more than 16 years of age. And probably, in fact, the newer guidelines from DGCI and in discussion with a lot of people, they say patient is asymptomatic and probably no symptom, age is less than 30, you should not use any antiviral for that matter.
Yes.
So,
Yes, I agree.
that is how the notion is. So that is what we do. So anyone who has got any mild symptom, then we give. Per patient who's young, totally asymptomatic, just accidentally detected, COVID positive, probably we can still hold on. In fact, I hold on antiviral for that matter, unless there is a symptoms to happen.
I completely agree with you. I completely agree. Next page, please. Now, drug interactions. There are interactions with pyrazinamide, but I think we will stop ATT for those 7 to 10 days. It will not help in, not make much of a difference. Ripaglinide, yes. Theophylline, again, yes. Famciclovir and Solindac. I mean, all these drugs are theoretical. I don't think while treating COVID, we use any of these medications unless they are life-saving. So it's safe to skip this. Next, please. Now, benefits of starting early antiviral therapy. Obviously, we've discussed it, that it helps in faster viral clearance and recovery, reduces the chances of hospitalization, overall treatment, and limits the future complications of post-COVID-19 is because the disease has not progressed. We've cleared out the virus, we've caused a faster recovery, so obviously complications, the chances would be far lesser than a symptomatic positive patient. Next, please. Now, treatment of family members. Currently in home quarantine, azithromycin, zinc, vitamin C therapy is being used. I strongly discourage all of this. And azithromycin is an antibiotic. It does not help in a viral illness. Zinc and vitamin C has just increased the over-the-counter usage. It has got no role in an antiviral clearance. Numerous studies have indicated that. Dr. Rathi will strongly agree. I can see him smiling there in the background with all these remedies. And the role of antiviral therapy in asymptomatic patients, I don't agree with this at all. They should not be given anything, and they should just observe them. I mean, I would say just monitor their saturation and temperature twice a day. Probably repeat their inflammatory markers every 3 to 5 days. I mean, if they are asymptomatic and if the inflammatory markers are going up, then maybe steroids would be given on an OPD basis. Apart from that, nothing. Just 14 days of rest and isolation. Now, not even 14 days is required. The new CDC guidelines tells us that 10 days is more than enough. What about you, Dr. Rathi? What do you feel on this cocktail which is being used by everyone?
I think we were also part of that, cocktail. We used to, patient expect a lot of you from
Yes.
doctor. So it may be not as in choice, but as in force you to tend to write certain drugs. And we all know because they are harmless to certain extent. So we try,
Yes.
but definitely there is no azithromycin in any of my prescription. In fact, I've stopped azithromycin, hydroxychloroquine, everything. Probably an antiviral. And maybe if there is some some PPIs or some paracetamol or something like that.
Correct.
And I ask them to drink. So a lot of water, a lot of good rest, good food, and probably just monitoring them well. That should suffice. COVID in a mild cases to asymptomatic cases.
I completely agree. Like asymptomatic patients would be in just nothing. Mild cases, symptomatic treatment plus or minus antiviral depending on the progression and thing. If patient is maybe having a continuous fever for 2-3 days, then we will consider giving an antiviral. Otherwise, if there's one episode of fever and subsides with dolo, I don't think anyone will consider a antiviral also. But you likely said that a close watch is very, very important because we've seen that 10 to 20% of these asymptomatic patients tend to become symptomatic.
Yeah.
And they often tend to become overconfident that, it's a mild disease. So they start neglecting their health. Which is why strong vigilance by doctors like you and me is important. And that's why our patients do well because we keep a strict watch on them. I think it's something is very, very important. You've very, very well said. Next page, please. Now we've discussed the post-COVID complications, fibrosis, serious complications, diabetes, hypertension, DVT, blurring of vision. Next, diagnostic test, post-COVID-19 recovery. A single breath count, a peak flow meter, CBC, D-dimer, cardiac evaluation, sugar. Now, I think this is a very subjective thing and it depends from patient to patient, depending on how severe the disease was in the patient and how fast they recovered. So I would say it's very subjective. What are your thoughts on this, Dr. Ali?
Yeah. So it all depends on what was your discharge card like.
Exactly.
The discharge card was very, the course was very stormy. Patient has been discharged from ICU. What was the length of stay in ICU? How much day he was on oxygen? What were the parameters at time of discharge? So that will actually make you to write, further prescription or investigation and maybe follow up. So probably 80% of your patient will require maybe a one follow up or probably two follow up, and that's it. But the patient who were on ICU, probably 15 days in hospital, then probably you will do all this test and just to evaluate the complications. And sometimes, it also make them aware of the disease per se. It's going to be a long COVID in some patients where you need to monitor him, and where you probably there might, whatever all complications we are talking about, they generally happens 7 to 10 days after discharge. So that is the period. So probably another 2 weeks after discharge are very critical in a given patient who is going to be a little more tricky patient at the time of discharge.
Very well said. I agree with you completely. So that's the end of our discussion on COVID-19 hit hard, hit early. It was a wonderful presentation. I sincerely thank Dr. Rathi for being a part of this talk and giving his wonderful insights and thoughts. I'm so happy that we share the same wavelength in managing COVID-19 patients. It's very nice to have a pleasant interaction.
Thank you, Avya,
Thank you,
for that
Saira.
wonderful. You have been superb and very brief and very informative about this hit early, and I think that is the concept. I think that is very well. Now the concept is that as we use broad spectrum antibiotics, as an empirical in a lot of patients. So I think this COVID has taught us to use more antiviral as an empirical. Probably in this pandemic, there is more the chance or more the time. 9 out of 10 times we will be right in using antiviral. Probably it is not that toxic as compared to antibiotics, and probably we can hold on after 5 days, where we tend to continue antibiotics for more period of days. So I think we have to hit early, we have to hit hard, and probably that will save more lives rather than saving the life once patient go to the moderate or severe category. So I think the mantra is very right. Probably we are doing that, and probably I wish everyone who's listening, everyone who's practicing COVID, or everyone who sees this COVID patient, they should follow the same. So don't wait for RT-PCR, don't wait for CT scan. If you've got high index of suspicion, if everything fits into that little you connect the dots, and in this pandemic, probably you will be right in starting an antiviral. You can always take off antiviral once the report is negative or you feel that. But then if you miss that first 48 hours, probably then the damage has already been started, and then you are actually then you are actually catching the bus. So I think that is how it should be. That is how we have burned our fingers and we have learned. So probably this is the crux what we have seen in last 9 months, what Ave has given to you. I think it was summed up very well. Hit early and hit hard.
Thank you, Dr. Rathi. We have a couple of questions. Now, the first question is by Dr. Nitin Lodha. He's asking us in what sense antiviral favipiravir helps in a COVID patient. I think we've discussed this, that it helps in the faster viral clearance and it reduces the hospital stay and cost of treatment. The next question is by Dr. Srishti Shukla, who's asking what is the role of X-ray in COVID-19? Dr. Rathi, over to you.
I think X-ray is very non-specific, and it has got a lot of inter-observer and intra-observer variability also. Plus, it all depends on what stage. There are very subtle peripheral shadows which you can see in X-ray, but they are very difficult to actually because the CORADS pattern has been now so well set, and now it has been approved by all the bodies, and the patterns of atypical viral pneumonia are so significant, and we can pick them up so early. In fact, with them, we can pick up them 48 to 72 hours before it appears on chest X-ray. So I think if you are in a doubt, if you want to do a test, and if it is available to you, probably now there is a lot of capping, so money is not a big issue now for a scan. So probably go for a scan. You will actually make your patient to realize, and it also help you to make a decision whether to keep patient at home or whether to shift patient to a hospital.
Fantastic. That was a very well answered question. I don't think we have any more questions. So if that is done, Saira Manohar, I think we can end today's session.
Yes, sir. Sir, thank you. First of all, I want to thank you both of you for sharing your valuable experience and addition to this program. With your experience and your thought process and the practice which you are doing, definitely the thoughts which you have shared will be helpful to all the delegates who are attending this webinar, and will be useful to you. And once again, on behalf of Hetero Healthcare, I thank you both of you for giving your valuable time and sharing your valuable experiences with us. Thank you very much. Thank you, Dr. Abhay. Thank you, Dr. Rati. Thank you. Thank you so much.
Thank you, Hetero. Thank you, Dr. Rati. Pleasure having you on board. Thank you.
Thank you, Abhay. It was pleasure having listening to you. In fact, I've loved your presentation and the way you have taken it. Probably let's